microphones on, ladies, gentlemen?
We're good. Yeah.
We left it off.
Yeah, he turned it on, but it's working.
Good morning. We want to welcome you this morning to our Grand Rounds presentations. Those of you that are joining us on the internet, we want to say welcome. You're in for a big treat. These are some of our first-year medical students in their first semester of medical school who have completed 3 classes so far. They've completed their MCM section, their host defense mechanism section, and they've just completed their musculoskeletal section. And we're going to have 2 cases that'll be presented by each group, and they'll be focused predominantly on the musculoskeletal system. For those of you that may not know on the internet, this is part of their medical informatics course. This course has taught the students how to resource a variety of different information, to bring up the latest in evidence-based medicine, and to work as a team and collaborate among others. The teaching staff here has aided and given them some suggestions of how to put this presentation together, but they haven't done the work for them. All the work is done by the medical students. So without further, and then comments and questions, you can definitely ask any question if you're online. You can submit those questions, and there is a link to this particular case, so you can definitely do that. And those of you in the audience who have any questions, feel free to submit those questions on a card down here to the participants. So without that said, we'll go ahead and turn it over to the next young man.
Good morning, everyone, and thank you for coming. Welcome to Grand Rounds. I'm student Dr. Landon Sowell, and I will be the first presenter for Group 7 today. Our case is over a 62-year-old man with worsening shoulder pain. Here are the names of the student doctors that worked very hard to put together this case. Let's begin with some background. The patient is a 62-year-old male who presented with right shoulder pain, which has gotten persistently worse over the past 2 months. There is progressive swelling over the right acromioclavicular joint, and the patient presented with no fever, erythema, or warmth of the right shoulder. There was no drainage from the mass, and the patient reported no recent heavy lifting or trauma. His past medical history includes hypertension, coronary artery disease, and end-stage renal disease in which he is hemodialysis dependent. His past surgical history includes a left brachiocephalic fistula. Here are the list of medications that our patient is on. The first 3 are for controlling his hypertension, and the last 3 are for aiding in his dialysis treatment. The patient has no known drug allergies. The patient reports no use of alcohol, tobacco, or illicit drug use. His family history is unknown. Our patient's vital signs were within normal range for someone of his age, and his general appearance was that of a well-appearing middle-aged man that presents with no acute distress. During the cardiovascular exam, normal extremity pulses were noted, and a positive bruit was heard in the left arm brachiocephalic fistula with palpable thrill. A thrill is a vibratory sensation felt on the skin overlying an area of turbulence. This turbulence is a result of the arterial venous anastomosis created for our patient's dialysis treatment. Musculoskeletal exam findings reveal a large, superficial, tense, fluctuant mass over the right AC joint. There's also significant tenderness to palpation over this region. And both internal and external rotation of the right shoulder are impaired secondary to pain. The patient was unable to lift his right arm past 30 degrees of forward flexion and abduction. There also appeared to be right rotator cuff muscle weakness. The skin of the right shoulder is intact, as well as no erythema or excess warmth in the right shoulder region. The neurological exam was unremarkable with distal motor, sensation, and reflex examinations. Here is our patient in this case. As you can see, the superficial mass over the right AC joint. An X-ray showed negative for fracture, and a high-riding humerus was seen. An advanced deformity of the humeral head is also seen. There is a large soft tissue mass over the right AC joint. MRI exam was performed as well. MRI results showed a large amount of fluid in the subacromial subdeltoid space. It was also noticed that there was fluid freely communicating with the glenohumeral joint, within the glenohumeral joint. And the MRI also showed a complete supraspinatus tendon tear. And there was a 5 centimeter gap measured between the supraspinatus tendon and the insertion site here. There was also abnormal signal intensity within the articular surface of the head, as you can see in this dark area. This is consistent with avascular necrosis. The humeral head is also seen to have subluxed superiorly. Lab test results were as follows. The C-reactive protein, erythrocyte sedimentation rate, and complete blood count were all seen to be normal. A microscopic examination of fluid aspirated from the mass shows no sign of infection. Having considered our patient's history, physical exam findings, and lab findings, we will now begin to think about our differential diagnosis. The first we will explore is lipoma, followed by we'll look at the possibility of a subclavian aneurysm, then an abscess, and lastly, an AC joint cyst. Lipoma. The clinical manifestation of lipoma is that it usually presents as a non-painful, mobile mass with characteristic soft, doughy feel. The overlying skin appears normal, and lipomas can usually be correctly diagnosed by their clinical appearance alone. Lipoma is a benign tumor of mature fat cells and is the most common soft tissue tumor. This is an individual with lipoma. Lipoma develops slowly, gradually increasing in size over months, and the diagnostic criteria of a patient with lipoma include the patient is afebrile, no drainage from the mass is noted, there's no overlying skin changes, it's usually non-tender, and no fluctuants. There is an increased incidence associated with those who have diabetes, those who are obese, and those who have hypercholesterolemia. It should be noted that the patient did not have drainage from the mass. The mass itself developed slowly, gradually increasing in size over months, and no overlying skin changes were noted, as well as the patient was afebrile. And looking at the MRI comparison of lipoma on the left here and our patient on the right, you can see in lipoma there is no drainage of fluid from the mass that's observed, and lipoma has the same signal intensity of that as subcutaneous fat. This is unlike our patient's MRI, which shows fluid clearly communicating within the glenohumeral joint. In addition to these findings, the mass is non-tender to palpation or fluctuant. So we can determine that lipoma is a test of someone with an abscess will include an elevated white blood cell count, which correlates to an infection. It should be noted that our patient's mass was tender to palpation and fluctuant, but due to our patient having a normal complete blood count indicating no infection, a slow onset mass, and no warmth or erythema to the area, make it unlikely that an abscess is our final diagnosis. Lastly, we will look at an AC joint cyst. An AC joint cyst will present as a membranous sac or cavity of abnormal character containing fluid. As you can see in this photo, this is an individual with a right AC joint cyst. The cyst will develop slowly over time, and the symptoms include a large non-pulsatile mass. The patient will have shoulder pain, particularly with movements of the glenohumeral joint. There is an increased incidence associated with a rotator cuff tear, degeneration of the joint capsule, and those who have osteoarthritis. AC joints are also more prevalent in an older population. Our patient's mass was large and non-pulsatile. He presented with shoulder pain, and the MRI showed a torn rotator cuff tear. And our patient fit the age description. This makes our final diagnosis that of an AC joint cyst. For further discussion of our final diagnosis, I'd like to now introduce student doctor Anand Shiva Prasad.
Thank you very much, Student Dr. Sowell. Good morning. My name is Student Dr. Anand Shiva Prasad. The acromioclavicular joint is one of 5 joints located at the shoulder girdle. It is a plane type synovial joint that allows for protraction and retraction of the scapula. Of significance to our patient is the AC joint's location, which you can see right here, that it's located adjacent to the glenohumeral joint, which you can see right here. Although an AC joint cyst is uncommon in AC joint disease, it is certainly not unheard of. The glenohumeral joint capsule degeneration combines with the rotator cuff tear or instability and allows for synovial fluid to flow superiorly into the AC joint capsule. This will present itself as the geyser sign. There are 2 types of AC joint cyst. In the first type of AC joint cyst, there's AC joint degeneration and increased fluid production. You can see what an AC joint cyst would look like here in this picture, with the cyst lying superior to the acromioclavicular joint. A type 2 cyst would have a complete tear of the rotator cuff muscles, which you can see at this location here in the picture. A type 2 cyst would have the following types of arthropathies: mechanical instability of the glenohumeral joint, superior migration of the humeral head, and deterioration of the inferior AC capsule. This would lead to increased fluid production, which would present itself as weeping, which is when fluid moves through the skin pores of the cyst and appears on the outside, giving the cyst the appearance that it's weeping. This can lead to a redundant joint capsule, which is simply put when the joint capsule becomes too large to house the joint itself, and would have the presence of the aforementioned geyser sign. Now you may be wondering about this geyser sign, and you can see this here on the MRI. It's this darker portion, and what that is the fluid moving from the glenohumeral joint through the acromioclavicular joint and into the acromioclavicular cyst right here. Now, initial treatment of an AC joint cyst is conservative, consisting of physical therapy, pain and anti-inflammatory medications, and the scheduling of a follow-up appointment in 2 months to determine if further intervention is necessary. Pictured here, you can see some of the exercises that a patient might do in order to help strengthen their scapular muscles. As future osteopathic physicians, it is very important for us to consider the need for and efficacy of osteopathic manual manipulation in the treatment of our patient's case. Some techniques that may be beneficial to our patient are scapular myofascial release and the Spencer technique. Both of these can be seen demonstrated here in this short video.
This is Spencer's technique. First, you're going to take the joint into extension and then flexion, moving further into the restricted barrier each time. This can be done 6 times. The next motion is bringing the shoulder joint into abduction and then abduction. Also going further into the barrier each time to increase range of motion. Then we're going to load into the shoulder joint and do circumduction, starting with small circles and then getting to bigger circles. You can do this counterclockwise and clockwise. Next, you're going to put traction on the joint, pulling up, and then doing circumduction again with small circles, getting to larger circles. This can be done clockwise and counterclockwise. Then you'll bring the joint into internal and external rotation by placing the hand on the small of the back. This can also be done 6 times, moving further into the barrier each time. Lastly is a myofascial technique. I'm just going to grasp the medial border of the scapula and pull until you feel tissue release. This can be done rhythmically or in one motion.
In the case of our patient, it was highly recommended that they undergo a total shoulder arthroplasty. In a total shoulder arthroplasty, an incision is made along the deltopectoral groove and a camera is inserted into the area to allow the surgeon to more easily view the procedure that is happening. The head of the humerus is replaced with a smooth metal ball that is inserted surgically into the diaphysis of the bone. The glenoid socket is shaped out with a reamer, and then the new prosthetic socket is cemented into the place. The goal here is to alleviate pain and increase the shoulder's range of motion. Now, over the next couple slides, I'm going to discuss a few new treatment methods for rotator cuff pathologies. One such technique is reverse total shoulder arthroplasty. In this technique, the ball and the socket are reversed to allow for deviation from the standard rotator cuff muscles to the deltoid muscle for complete movement of the shoulder. This is a novel prosthetic clinical trial in which modifications of structural aspects of the system have been altered to help improve past problems with reverse total shoulder arthroplasty surgeries. In order to be considered for this trial, a patient must meet at only one of the 8 following criteria: avascular necrosis, gross rotator cuff deficiency, osteoarthritis, rheumatoid arthritis, ununited humeral head fracture, irreducible 3- and 4-part proximal humeral fractures, and a past failed total shoulder arthroplasty. That our patient presented with a avascular necrosis and a gross rotator cuff deficiency was a significant indicator for surgical intervention and for deviation from future reliance on rotator cuff muscles. On this slide are some of the past problems and some of the potential benefits that have arisen from this procedure. Some of the problems include scapular notching, rotation deficiency, early implant loosening, and dislocation of the joint. Some potential benefits have been reduced pain and improved muscle strength, and as well as increased range of motion at the shoulder. 80% of patients have reported scapular notching. Due to repetitive contact between the polyethylene of the humeral component and the scapular neck during shoulder adduction, erosion of the scapular neck may occur, as well as polyethylene wear and inflammation. These problems typically arise 6 to 14 months post-surgery and can lead to graded adduction deficits and, in some cases, glenoid loosening. Now, as a physician, when you're working with a patient who may need a surgical procedure, it's important that you stress to the patient the pros and the cons of both the operative and the non-operative procedures. A patient may need 4 to 6 months post-surgery in order to recover, and may need 2 to 6 months in order to return to daily activities. This can lead to not only loss of income and neglect of social obligations, but can also lead to negative effects on other aspects of that patient's health. It is important that the doctor assist the patient in having an appropriate support system in place, and that the patient receives appropriate instructions to maximize the efficacy of conservative and surgical treatments. Now, most primary care physicians are going to come across shoulder pain at some point in their career, as is the third most common reason for musculoskeletal consult in primary care. Somewhere between 16 to 20% of the population will suffer from shoulder pain at some point in their life. Now, when you're treating a patient, it's important to keep in mind that not only do they have their chief complaint, but there might be underlying problems here as well. In the case of our patient, they reported with a visible acromioclavicular joint cyst, but the underlying problem was the complete tear of the rotator cuff. Thank you very much. And I understand we have some questions from the audience, so I will go ahead and turn the floor over now. Thank you.
Okay, so I know you have questions, so who wants to start first?
Student Dr. Thomas Stewart. We got a question about how common AC joint cysts are, and they're pretty rare. A review of the literature was done in 2010, and they were able to find only 41 documented AC joint cysts. 36 of those actually involved a complete tear or avulsion of the rotator cuff, as we saw in this case.
All right, student Dr. Quentin Tuckfield, and there were several questions about the aspiration of the cyst and if that was efficacious or what was contained in the cyst. And so the surgeon did aspirate the cyst and found what was classified as gelatinous bloody fluid, so a mixture of blood and that synovial fluid that is recidivating in that cyst. And so the cause of that cyst, the underlying cause is that torn rotator cuff and the degeneration of the joint capsule. So merely aspirating the cyst would provide temporary relief, but with the underlying cause being the torn rotator cuff, it's necessary to repair that rotator cuff as well as the joint capsule, or that cyst will continue to regrow and recidivate.
I'm student Dr. Xinyang Xu, and we get a question about, will the cyst stay in the AC joint and the glenohumeral joint area and can it migrate or radiate to other places? And then it is really rare to see, but yes, it's been reported in the literature back in 2004. And then the AC joint cyst will penetrate the trapezius muscle and then forming intramuscular ganglia. And then this ganglia could be differentiated from the AC joint cyst by seeing there's synovial lining, and the formation caused by the mucoid degeneration and deintegration of the fiber in the connective tissues.
Hello, I'm student Dr. Usla Syed, and I actually have 2 questions here. So the first one I'm going to start off with is what's a fluctuant mass? And this was brought up multiple times in our case, and it's related to the AC joint cyst that the patient presented with. And basically, when you're talking about a fluctuant mass, this is just a description of how the mass feels when you're palpating it, and it's just going to be a wave-like motion, and this is due to the fluid that's found in the cyst. And the second question is, what is subluxation? And the short answer for this is just partial dislocation. And it's just when a bone that's making up any kind of joint is forced out of its natural alignment due to excessive stretching. And that could be due to a ligament tear or a capsule tear. Thank you. Okay.
I'm student Dr. Matt Ziem, and we had a question come to us on the chat room from, well, it asked, what led to the avascular necrosis of the glenohumeral joint? And avascular necrosis can be caused by a couple different things, one of which is long-term systemic use of glucocorticoids. They can interfere with our body's breakdown of lipids, which can clog the vessels, reducing the amount of blood flow to the joint. However, in this case, we only use cortisone after aspirating the cyst, and it's probably not likely that that was necessarily the cause. It's more probable that the necrosis was caused by repeated dislocations due to the glenohumeral joint instability, which could have compromised either the posterior or anterior circumflex humeral arteries.
I'm student Dr. Adrienne Yun, and I got a question about renal osteopathy, what it was. And renal osteodysplasia is basically an alteration in bone morphology that's usually seen with patients that have chronic kidney disease. And our patient who was in end-stage renal failure, and patients like him can't properly maintain their calcium and phosphorus, and this leads to the bone weakness, ultimately the change in morphology. And so because of that, our patient was taking sevelamer and cineselit, as well as the lanthanum to basically keep those levels up.
My name is student Dr. We got a question asking, was subacromial bursitis a consideration in this case? From what we were given, it was not considered in our case, but it could have been a differential. So the subacromial bursa is a sac of fluid which separates the acromion of the scapula and the rotator cuff muscles. And if this bursa were to become irritated or inflamed by repetitive injury to the shoulder or trauma, it could swell and kind of look like the mass we had, except that it would occur between the rotator cuff muscles and the acromion, which would mean that there probably wouldn't be a tear in the rotator cuff muscles, so that could be ruled out pretty quickly based on his imaging.
Hi, I'm student Dr. Twaddle. The question I got off the chat room was, how do you treat an abscess? So it really depends on the abscess. If it's a smaller abscess, it's advised to just use a warm compress and hopefully promote drainage of the purulent material that's inside. If it's a larger abscess, we'll typically be a bit more aggressive and do an IND, which is an incision and drainage, and that's done in ERs daily all across the country, and that's where you cut it open to allow the drainage to happen and encourage it, and then you can culture it and see if maybe the patient has MRSA, and then you can prescribe antibiotics as well, which is typically a 5 to 7 day course, and that's encouraged for multiple abscesses, big abscesses greater than 2 centimeters, if they have extensive cellulitis, or if you had a failed attempt at an IND that didn't heal as expected.
I'm student Dr. Michael Tarabiel, and we got a question about what is synovial fluid composed of. So I'm going to go ahead and answer what it kind of looks like, what it's composed of, and what its function is. Synovial fluid is actually an ultrafiltrate from blood plasma, and it contains proteins thus from the blood and also from local cells within the joint tissue itself. It actually has an egg white consistency, and it is viscous. Its chief role is of reduction of friction between the articular surfaces of the synovial joints, and also maintaining homeostasis of the nutrients and waste products found there. So some proteins that are found specifically in synovial fluid include hyaluronic acid, which is secreted by type B fibroblasts-like synovial cells. And this acts as an important coat around each chondrocyte in helping the cartilage itself resist compression. And also lubricin is found there, which is secreted by surface chondrocytes of the articular cartilage. This is a proteoglycan helping with lubrication and movement of the joint. And then also there are proteinases and collagenases helping with protein tissue homeostasis.
Are there any other questions? First of all, I want to compliment you on your ability to answer those questions that came in from the chat room and online. The comment relevant to aspirating that space is relevant because that really takes you down a pathway. If you've got pus, inflammatory cells in there, highly white cells, you're going to be dealing with an infection. That aspirate just had some serous type of material and nothing to reflect any underlying infectious process. So it did very well there. I thought all the content of your answers were spot on. It was a strong presentation. You would know that you would get the rare type of presentation you just don't see AC cyst very frequently. That's a common problem in clinical presentations with any physician who takes care of people to have shoulder pain. The likelihood of seeing an AC cyst is not very high. Overall, I thought the content was very good. I thought your knowledge of your presentations was spot on, and you did a very fine job in showing the comparisons of your images, one compared to the other. So, are there any other questions? Hearing none, give them a round of applause, and the next group come up.
Hello.
Hello? Hello? Okay. We good? Good? Okay. I'm student Dr. Sarah Brigham, and we're group 8, and we'll be presenting a case of unexpected cause of severe knee pain in an 8-year-old. So this is group 8. So our patient presented with a chief complaint of a 1-day history of right knee pain. Our patient is an 8-year-old male, and his mother stated that his pain began 1 day prior after playing outside with friends, but denied any incidents of trauma. This morning, when her son woke up, his pain had severely worsened. He experienced swelling and was no longer able to bear weight on his right lower extremity. They also took his fever at home and measured 103 degrees. So she took him to the primary care office, where after seeing there, and the fever was measured at 101 degrees, that coupled with his right knee pain and inability to bear weight, was sent to the tertiary care facility. It was also noted that the patient experienced an upper respiratory tract infection with a low-grade fever 1 week prior, and his symptoms have since resolved. The patient has no past medical history, is on no current medication, has no known drug allergies, and for family and social history, he lives with his mother. For our vitals, the patient was febrile at 101 degrees and was tachycardic at 122 beats per minute. His blood pressure was measured at 106/58. For the musculoskeletal part of the physical exam, the patient described a sharp pain on the anterior and posterior aspects of his right knee, which he rated a 10 out of 10. It's good to know that in pediatric cases, commonly the Wonk-Baker Faces Pain Scale is used instead of just a normal numbering system. Upon palpation, the knee was painful and warm. It also had mild effusion with overlying erythema. The patient experienced pain with flexion and extension. He was able to fully extend his leg, but could only flex to 30 degrees. It is also good to note that the patient was sitting with his knee flexed and hip externally rotated. For lab values, the patient had leukocytosis with an elevated white blood cell count of 13.1, had a mildly elevated C-reactive protein, or a CRP, at 4.1, and had an elevated erythrocyte sedimentation rate at 56. So an ultrasound was ordered, and a small amount of fluid was found in the suprapatellar bursa, but no fluid was seen in the popliteal fossa. Because of this, a joint aspiration of the right knee was attempted, but was unsuccessful, and no joint fluid was obtained. Because of this, because the ultrasound finding and the lack of aspirate obtained from the knee, a MRI was ordered. The MRI was ordered with gadolinium contrast. Gadolinium contrast allows for a better view of inflammation and swelling. Now, all of the findings were found in the lateral head of the gastrocnemius muscle. Now, the star on both images here represents inflammation of the popliteal soft tissue and synovitis, which is an inflammation of the synovial membrane there. The arrow on both is showing phlegmon, which is an area of inflammation with pus and microabscesses. So due to our patient's inflammation and pain, we came up with these 4 differential diagnoses: osteomyelitis, myositis, septic arthritis, and pyomyositis. For osteomyelitis, it is an infection localized to the bone. It is most common in children, specifically in the long bones. It is often found in settings of trauma or surgery, and with it you have limited macrophage or neutrophil activity due to the decreased vascularization. And here we just are showing an image of that localized bone infection as compared to normal. So, reasons why we thought osteomyelitis was a likely cause here was the tenderness and warmth at the site in the fever, and also the lab findings are consistent with what we had, which was that leukocytosis, elevated ESR, and elevated CRP. However, things that made us think that it was a less likely diagnosis was that it typically onsets over several days, and we just had the sudden onset. Also, edema is often seen inside of the bone, which is what we have an image of here, the edema inside of that. So because of the edema inside of the bone and the onset over several days, we ruled osteomyelitis as a less likely diagnosis. Next, we move on to myositis, which is acute muscle inflammation, typically affects school-aged children. It also starts off typically as an infection, and patients who are experiencing this have sudden difficulty ambulating or walking and have lower leg pain. So a lot of that fits with our patient's symptoms. He is of school age. He did have an upper respiratory tract infection a week ago, had sudden onset, and specifically our findings are in the gastrocnemius muscle, which is common for myositis. However, all of our lab findings should normally have been in the normal range, and ours were elevated. So because of our lab findings, we ruled myositis as a less likely diagnosis. So that brings us to septic arthritis, which is an infection of the joint. Bacteria infiltrates the joint capsule, and the immune response to this leads to a fluid buildup, which you can see here in this left knee as compared to the right. And with septic arthritis, you have restricted range of motion, fever, and pain. So that restriction of motion, fever, and pain are some of the things that led us to believe that this was a likely diagnosis. And for lab values, we also had leukocytosis. However, the age range that this typically presents in was not fitting in our case. It traditionally occurs in the elderly or in children under 3 years of age. It is also often seen after postoperative care or other soft tissue infection. Another big thing was the fluid filling the joint that I mentioned earlier. You would have been able to aspirate fluid from the joint, which we were not able to do. And you would also have leukocytosis that you would measure from the joint aspirate. So here's some images kind of demonstrating what I had just said about the fluid filling the joint. So this image right here is of septic arthritis, and this is the image from our patient, and you can see we do not have that large fluid-filled area. So that leads us to pyomyositis. Pyomyositis is an infection of skeletal muscle. It develops in 3 stages, resulting in abscess formation. That is what this image is of here. This is an abscess in the lower extremity. It often is seen after muscular trauma and is usually seen in immunocompromised individuals. So, for clinical manifestations, we had pain, and it's most common in the lower extremity. We had muscle cramping, mild leukocytosis, aspiration is negative, and the abscess is not palpable. And our lab and radiology findings fit. So that led us to believe that pyomyositis is our most likely diagnosis. So to review, osteomyelitis wasn't likely because of the edema inside of the bone. For pyomyositis, our lab values were elevated and not within the normal range. And for septic arthritis, we did not have that large fluid-filled area in the joint. So for more information on pyomyositis, I will turn you over to student Dr. Derek Clary.
Thank you, student Dr. Brigham. My name is student Dr. Derek Clary, and I'll be taking a closer look at pyomyositis. Pyomyositis is also known as myositis tropicans or tropical pyomyositis because it is most commonly found in tropical climates. In rare cases, it has also been seen in temperate climates as well. So what exactly is pyomyositis? It's a subacute bacterial infection of the skeletal muscle resulting in abscess formation. It is most common in the lower extremities and pelvic girdle, specifically the iliopsoas muscle. Predisposing factors to pyomyositis include recent muscular trauma and immunodeficiency, such as HIV, cancer, and autoimmune disease. Staphylococcus aureus is the most common pathogen for pyomyositis infections. 25% of these Staph aureus infections are MRSA, methicillin-resistant Staphylococcus aureus. Pyomyositis can also be polymicrobial as well. Today, we will be focusing on pyomyositis with Staph aureus infections. Skeletal muscle is normally resistant to bacterial infections because it sequesters iron in its myoglobin. Without a readily available source of iron, bacteria do not have the necessary means for cellular respiration. Trauma to the skeletal muscle allows for the release of myoglobin and provides an iron source for the bacteria. In pyomyositis infections, this muscular trauma is often associated with a break in the skin barrier to allow entrance of this bacterial pathogen. In the human body, the host creates a myoglobin-haptoglobin complex in response to myoglobin released into the extracellular environment. Staph aureus is able to bind to this complex and obtain iron through many steps of bringing the heme past the cell wall, past the cell membrane, into the cytoplasm, and breaking it down into usable iron. There are 3 stages of the pyomyositis infection, each increasing in severity and damage. Stage 1 is also known as the invasive stage. It is early in the infectious process, and symptoms are fairly mild, including muscle cramping. As long as there is no bone or joint involvement, treatment is easy with antibiotics. In the second stage, also known as the suppurative stage, pus and abscess formation occurs. This is the most common presenting stage and occurs 10 to 21 days after onset. In this stage, the patient will experience fever and extreme muscle tenderness. Stage 3, also known as the late stage, is the most dangerous and severe stage of infection. In this stage, there's risk for muscular necrosis, systemic shock, and even death. In both stages 2 and 3, the proper treatment includes antibiotics and drainage, either in the form of an incision and drainage or percutaneous drainage. In incision and drainage, the localized infection is lanced with a scalpel, as seen in the picture above. The wound is then often packed with a wick to further fluid drainage. Percutaneous drainage is an image-guided technique in which the infection is removed with a needle. Then a small drainage catheter is placed to further the fluid drainage. After the drainage procedure is performed in stages 2 and 3, it is important to culture the removed fluid. This way, a more pathogen-specific antibiotic may be prescribed for treatment. In all stages of pyomyositis infections, empirical antibiotics are prescribed. When prescribing antibiotics, there are 2 major factors to consider. First, the community prevalence of MRSA, and second, the immunological competence of the patient. Due to the resistance of MRSA to clindamycin in certain regions, it's important to know the patient dynamics within the community. If there is a low MRSA prevalence within the community, clindamycin will be the first choice of antibiotic prescription. If there is a high MRSA prevalence, vancomycin will be the first choice. Secondly, it is also important to consider the immunological competence of the patient. For immunocompromised patients, vancomycin is prescribed empirically along with a broad spectrum regimen that protects against both gram-negative and aerobic and anaerobic bacteria. Clindamycin is a bacteriostatic antibiotic and works by binding the 50S subunit exit tunnel of the bacterial ribosomes, therefore inhibiting protein synthesis. Nucleotides A2058 and A2059 are the main interaction sites for clindamycin. Bacteria with mutations of these nucleotides have increased clindamycin resistance. If the cultures of drained fluids in stages 2 and 3 result in MSSA, methicillin-susceptible Staph aureus, it is important to switch to a beta-lactamase inhibitor antibiotic, such as a cephalosporin. These antibiotics are well tolerated and have a bactericidal effect as opposed to a bacteriostatic effect, such as that of clindamycin. For the patient in our case, he was found to be somewhere between stages 1 and 2. He was admitted to the hospital for one night and treated empirically with IV clindamycin. By the next morning, there was marked improvement of his pain and overlying skin changes. The patient was able to walk and bear weight. A PICC line was then placed, and the patient was discharged home on clindamycin for 3 weeks. A PICC line is a peripherally inserted central catheter, usually into the veins of the arm. It is placed for venous access over prolonged periods of time. Proper care of PICC lines are important to prevent infection and potential embolism formation. Bacterial resistance to antibiotics has become an increasingly important issue in medicine as bacteria continue to evolve mechanisms to increase their antibiotic resistance. In response to this resistance, alternative antimicrobial agents, such as silver nanoparticles, have been explored. Silver nanoparticles are bactericidal in nature and act in multiple ways to kill both gram-positive and gram-negative bacteria. One of its multiple bactericidal mechanisms is the binding of silver nanoparticles to proteins of the DNA. This will denature the proteins of the DNA and therefore disrupt it. Since silver has multiple ways to kill bacteria, even if bacteria develop resistance to one mechanism, silver can continue to kill bacteria through other bactericidal mechanisms. It's important to note that with pyomyositis infection, there is a contraindication to OMM treatment to prevent the spread of this infection. In this case, OMM is viable only after antibiotic course has been completed. At that time, it is now acceptable to assess range of motion of the affected muscle group and treat accordingly. In addition, we can use lymphatic pump techniques beginning and ending with a thoracic inlet to increase lymph flow centrally. In pediatric cases, it is imperative to obtain parental consent for any diagnostic or treatment options. It's important to ask both the child and the parents about any possible trauma or recent injury. Oftentimes, depending on the patient's age, children cannot disclose all important information about their medical illness. Therefore, when diagnosing pediatric patients, astute observational skills are key. Lastly, as with any pediatrics case, we want to ensure the safety of the child, and it is always important to consider the possibility of abuse. In our patient's case, appropriate PICC line care is emphasized. We will also emphasize the proper usage of antibiotics. It's important to take probiotics, such as yogurt, along with any antibiotic prescription to help prevent potential Clostridium difficile infection. Lastly, it is especially important to complete the entire course of an antibiotic prescription, even after the symptoms have resolved. In conclusion, pyomyositis is a subacute bacterial infection with pus formation, most commonly found in the lower extremities and pelvic girdle. It's important to note that if the infection is allowed to progress to the late stage, myonecrosis can occur and potentially lead to septic shock and death. This emphasizes the importance of empirical antibiotic treatment with broad coverage. As a last take-home message, bacterial resistance to antibiotics is becoming a rapidly pressing issue. It's important for physicians to follow the guidelines of antimicrobial stewardship and be diligent in prescribing the correct antibiotics when appropriate. It is equally important for everyone that when prescribed antibiotics, the entire course is completed to prevent further mutation of antibiotic resistance. We would like to thank these staff members for dedicating their energy and effort into our project. Thank you all for your attention and time. We will now open the floor for questions.
I'm student Dr. Capelli, and for the first question we had was, what is the most common cause of septic arthritis in a female of reproductive age? And to talk about this, again, we have to look back and say that in general, there are two causes of septic arthritis. One is non-gonococcal, and the other one is gonococcal. So in gonococcal septic arthritis, what we have is a gonococcal infection, it being the method of introduction for that bacteria into the body. And this is the most common form of septic arthritis seen in reproductive age women. This subset of septic arthritis, reproductive age women, and gonococcal infection actually it causes up to 7% of all septic arthritis cases in the U.S.
Hi, I'm student Dr. Sam Ballard. I got a question. When would you not use gadolinium in MRI scans? There's two major contraindications. The first one is if you're at risk for nephrogenic systemic fibrosis, in which your kidneys are insufficient and they can't filter the gadolinium, so you get the scarring of the skin and internal organs. And superficially, you get the discolored and hardened plaques and nodules on the skin. The second major contraindication would be if you are allergic to gadolinium, which is very rare. It occurs in like 1 in 10,000 people. And another contraindication would be if you can retain gadolinium in your system. And the clinical significance and long-term effects are still unknown on that.
Hi, my name is student Dr. Saad Chaudhary, and I had the question, how else are silver nanoparticles used in the medical field? So as of now, so it was in our emerging research slide. So basically these have a very important part of the upcoming research. They have a very wide range of roles in the research that's going on now. They can be utilized efficiently because they can be engineered to have a specific selectivity, size, shape, and even their biocompatibility. And as we've previously seen, they can also be used as bactericidal agents against Staphylococcus aureus and other gram-negative bacteria. And one of the things that I thought was pretty interesting is that how they can be used as a drug delivery system. They can actually be used to protect the drug that they're going to be delivering from certain pH changes within the body. And due to their obviously their nanoparticle size, they can also cross certain biological barriers, such as the blood-brain barrier. However, I really can't find any topics regarding if they have been able to be used regarding treatments for any type of brain disease.
Hi, my name is student Dr. Ahmed Hassan. I'm answering the question, what is a phlegmon? A phlegmon is an inflammation of connective tissue, and there's two types basically. There's superficial and then there's deep. The superficial one is right under the skin, and the deep is next to the organs and tissues. The most common organ that phlegmon is located near is this tonsil, and it doesn't really spread as easily, so it's very localized. That's what a phlegmon is. Thank you.
I'm student Dr. Jacob Beecher, and I got a question. What is Munchausen syndrome? This is a syndrome where a patient will make up a factitious disorder and come into the office and either falsify medical or psychiatric symptoms. In this case, this is particularly important in the situation of Munchausen's by proxy, where which is actually a type of medical child abuse, where an individual will impose symptoms or even injure children just so they have the ability to bring them into the office, even if there's no personal or financial gain to it.
Hello, my name is student Dr. Evan Buckmiller. There were two questions I'm going to answer. First was, what are the common pathogens of septic arthritis? And in healthy adults, we see more commonly the Staphylococcus aureus, as well as streptococcal species, in particular Streptococcal agalactiae, Neisseria gonorrhea, and in immunocompromised patients, we see aerobic and anaerobic gram-negative bacteria, mycobacterial species, and functional species, including the sporotrichosis, cryptococcus blastomycosis, and coccidioidomycosis fungal species. We also see mycoplasmic infections in the immunocompromised hosts as well. We see brucellosis can be a possibility in patients who are in contact with animals a lot, as it's zoonotically contracted. The second question is about, is this boy a typical pyomyositis patient? In fact, this patient, this is very odd case, very rare. As was previously mentioned, pyomyositis is traditionally a tropical pathogen or disease, thank you, that has, as of recent years, started to show up more commonly and more frequently in more temperate climates. In the tropical climates, children of ages 2 to 5 and adults ages 20 to 45 are the most common age groups, noting that males are more commonly affected than females. And however, in temperate climates, most of the patients of pyomyositis are adults who are healthy with some of the predisposing factors of normal ages 20 to 45.
Hi, student Dr. Desiree Albano. So we received a question asking what are siderophores. In order to answer this question, I have to give a little bit of background on iron. So iron is an essential cofactor for many biochemical reactions. It's vital for the growth and proliferation of all organisms, but specifically bacteria. Vertebrates have developed methods for sequestering iron in proteins in order to restrict the amount of iron available for invading pathogens. And in order to circumvent the sequestering of iron, bacteria have likewise developed mechanisms for obtaining iron during infection. So Staph aureus, which is the bacteria that was involved in our case, pyomyositis, is heavily dependent on iron acquisition for colonization, and it releases siderophores to do so. So siderophores are small molecules. They're considered virulence factors. They are secreted by bacteria, and they have a high affinity for iron. Staph aureus in particular secretes two types of siderophores, staphylophore A and staphylophore B, which are maximally expressed in iron-limiting environments. They target extracellular iron complex to host proteins, transferrin and lactoferrin, and transferrin and lactoferrin are your major iron binding and transporting proteins.
Hi, student Dr. Sarah Barstow. We received a question, by what route would an infection such as this reach the knee region with no associated overlying injuries in the patient's knee? And so to answer this question, it's important to note that pyomyositis is an infection of skeletal muscle that arises from hematogenous spread. And hematogenous spread is defined as spread by way of the bloodstream. And it's also interesting to note that pyomyositis has been described in temperate regions, often among athletes performing vigorous exercise, suggesting the potential role of minor muscle damage in the pathogenesis of this disease. So bringing it back to our case, our patient had an upper respiratory infection 1 week ago, which could potentially be where and how the bacteria entered his bloodstream. And it's also important to note that he's a young and active 8-year-old boy. He was outside playing with his friends yesterday, suggesting that he may have had minor muscle damage to his knee, which contributed to the pathogenesis of his disease.
That was a strong explanation. One of the questions I know that was submitted but didn't have time to get to was, did the young man have any blood cultures drawn? And that's important because this form of sepsis can have a hematogenous spread. So you want to make sure that there is no residual bacteria at all in the young man's bloodstream. The fact that they let him go in 24 hours, they're fairly confident that they had the definitive diagnosis. The other thing that I wanted to remind you of is when you examine any joint that appears to be warm, hot, swollen, you'll hear terms of boggy, puffy, and that's all the synovitis reaction. So when you examine that joint, let me have your hand. You come into the, whatever the joint is, with the back of your hand, not the palmar surface of your hand, because that's warm, sweaty, etc. So if there's any heat generated from that joint and the picture looked like that was a hot joint, you'll feel the thermal difference between those two joints. And last is that age group. You always got to think about some seronegative arthropathy or some juvenile onset arthritis presenting in a unilateral joint. But she played the odds and you answered that correctly, that it's a young 8-year-old kid outside playing and sudden onset of joint pain. I thought the content of your presentations was outstanding. You had good command, you had excellent explanations, and your imaging was done well. The way you answered your questions coming in from online and from the cards show that you've learned a lot in this section. So again, give it up, and we thank the folks for tuning in. Have a great day.